We had some questions along the way, but I guess if you've stored up some questions, I'm very happy to discuss them.
I have questions.
Sir, name?
Lars.
Hi, Lars.
Hi. I'm actually not from EKS. I'm from the university. I will introduce myself later if you have 5 minutes, but I'm leader of the Danish Institute of Healthcare Improvement, which I conducted the study for EKS.
Yeah.
So it was very interesting to hear this. My question is, looking at all the different countries that have accreditation systems and all the different kind of benefits, looking at a small country like Denmark with public hospitals and new public management governance system, what kind of benefits are most prevalent here in Denmark, would you say, compared to your country? Do you see any differences between countries and where the benefits from accreditation might differ?
Yeah. I think there are more similarities than differences.
Okay.
For example, once you get the accreditation model, you can't really deviate from it that much, regardless of the health system or what it is you're accrediting. For example, you have to somehow get standards. You've got to make them as sensible or as evidence-based as you can. You have to have a surveyor workforce. You have to apply the standards, and they're usually clinical or organisational standards, or some patient standards, clinical, organisational, patient. You have to have a mechanism to do that. You have to visit those hospitals on a regular basis, have them maybe do some self-assessment. So the model starts to look very similar, regardless of whether it's public or private or acute. Now, that's at a sort of broad level, but once you start to drill in, there's very unique aspects to people's standards, or the way they train the surveyors, or the indicators they have, or the criteria they have against the standards. So there starts to get levels of detail once you drill in. But largely, the system itself of accreditation is very similar across the world. We even found when we did a study of low and middle income countries who weren't wealthy like your country or mine, they had a very similar accreditation process. They may not have had the IT, they may not have had some of the sophistication of the models that we have, but accreditation looked very similar in some low and middle income countries where they had accreditation.
Okay, so basically...
I'm not sure if that answers your question, but it's the best answer I had.
Yeah, but so basically you're also saying that your research should be transferable to a Danish context.
At a broad level.
Yeah.
But yes, that's why I've really concentrated on saying about my research, because I don't have research in the Danish context, but also I'm saying generally at a broad level, I think it is transferable. More questions or comments or observations?
Yeah, I think that it's been so fruitful to hear your comments about how you do research, and you have heard a little about how we work, et cetera, et cetera. So I'm very much thinking of where would be the most important area or touch point or whatever where we could go in and think of improvement research project for our journey of development. So what's the most crucial thing for us to develop now? You heard we have the project that Peter mentioned about unannounced visits. We're having the development process of the standards. So what else could we do in your head to say where should an improvement effort be put in in an organization like ours, or a healthcare system like the Danish?
Thank you so much for your question. Yeah. If you could go to page 26. I think these are the next hot topics. Now, I'm not sure which one will apply in Denmark, but these are the next hot topics on page 26 and 27. Across the world, I think the role of government in accreditation schemes is one worth thinking about. I'm not sure if any of these translate, Niels, in the Danish perspective, but these are the ones that I think are on my mind as I look at research or the lack of it across the world in accreditation. One's the role of government in accreditation schemes. Often governments get involved. They start to fund accreditation. Often what happens then is governments are a bit dissatisfied, that they're not sure if accreditation has stimulated improvement. And then they can start to defund accreditation or even make accreditation programs have to earn their own salary from the organizations they accredit. That may not happen in Denmark because it's so publicly funded and publicly minded about the health system. But in some countries that has happened. Another one is financial viability. Government's sort of saying, okay, well, this needs to be financially viable. We're not going to keep pumping money into accreditation. You've got to earn your fees from the provider organizations. And then the dynamics of the power changes. And maybe then you feel more inclined to accredit people and give them a good result because they're paying you. So I wouldn't want that to happen. But I do think in some countries, accreditation has to become financially viable. Otherwise, it doesn't exist. I think the ongoing stakeholder acceptance and engagement in accreditation is very important, and I think that's worthy of research. And you're actually doing some of that now with your interviews. Over the page, I think there's a movement to try and make standards more evidence-based. At first, when people get accreditation, they kind of write standards that are roughly what they think the standards should be. But over time, having them more evidence-based is worthwhile and is something that could be researchable. There is a debate, not so much here, but whether we should have surveyors in the way you have them, where they're in the system embedded. But should we have professional surveyors, i.e. we train a smaller number and they survey all the hospitals in the country and they become expert salaried surveyors? If anybody's going that way, I suggest that's something worthwhile researching and saying what's the best method.
Actually, we might be employing a sort of mixed methods when it comes to GPs, where we will deploy survey teams of 2 persons, one of which will be a GP, who is working for us one day per week, more or less. The other person might be another clinical person from the practice setting working in the same kind, but it might also be a professional surveyor or a mix of both types.
Yeah, so that I would research that. I would have a look at the accreditation results of the people who are in the current mode of accrediting, your current peer-to-peer surveyors, and the professional surveyors or the dedicated surveyors, whatever label you give them, and see if their results change over time. So that's something that probably would be worthwhile researching. And then my own hope one day, there's been one randomized trial of accreditation. It was in South Africa about 20 years ago, where they looked at, as you say, there's contamination problems, but looked at giving half the hospitals in the sample accreditation and half didn't get it. And it did show that accreditation was worthwhile. It did show that accreditation was valuable. So I really am hoping for level 1 evidence. You know, level 1 evidence is if somebody's done a randomized sort of trial with a control group. I am hoping more for that over time. And we've tried to do that a couple of times and haven't quite managed to get it funded. The problem is you can't do a randomized trial of some group that doesn't have accreditation and some group that's going to get accreditation, because most countries have accreditation. So it's already contaminated. Mm-hmm. You could do it when you move to the next standards, though. You could move to the next standards and give half the people standards, the 4th level of standards, and the other half stay with the 3rd level and see if there's a difference in the quality of care. But it's, for reasons you guys both said, it's very difficult to do this because of the attribution problem is the reason why you got that result, because of the change in accreditation that you've induced. Let me tell you this. Okay, on this subject of should we do randomized trials in healthcare and give some people as part of the initiative and other people not, other hospitals not. Say we're talking about hospitals in a country. There's 23 million papers in PubMed. 23 million papers. You're behind in your reading, aren't you? There's 11 systematic reviews, that's summaries of the literature, published every day. There's 75 randomized trials published every day. Okay, that's the volume of medical research. How many of those papers in PubMed would you guess are studies where somebody has intervened at the systems level, right across the system, and done a randomized trial? That is to say, root cause analysis, when it first came into the country, it was mandated, okay? Instead of mandating it, give it to half the sample, and the other half don't have to do root cause analysis, measure them at baseline, and then measure them at time 2, time 3, and time 4, seeing if root cause analysis makes a difference, and seeing if root cause analysis, if it does make a difference, is sustainable. So all the things we've done in healthcare in the last 20 years, we've given accreditation, root cause analysis, hand hygiene programs, blah, 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 across the country, in almost every Western country. How many of those initiatives where we keep intervening at the systems level across the world, how many of the papers in PubMed are randomized trials at the systems level, rather than randomized trials of patients done by clinicians and researchers? How many do you think? Anybody know the answer?
Yes, you have a guess.
Have a guess?
0.
0? The pessimists can be over here. Any advances on 0?
5.
Excellent answer. You're wrong by an order of 1. There's 6. So 6 of the 23 million studies in PubMed are what I would call well-designed studies at the systems level, where somebody said, okay, we're going to intervene in the system and give something to the system. Say, root cause analysis, hand hygiene program, whatever it is. Before we do that, we're going to take some baseline measures. Then we're going to do the intervention. And then we're going to measure it time 2, time 3, and time 4, and see if we actually produced a result. And we're going to have maybe some of the people get it first, and the rest are a control group. So that's what I call a well-designed intervention at the systems level. There's 6 studies. So we're on a revise and resubmit with a journal at the moment, publishing a paper saying exactly that. So, can we get level 1 evidence for some of the things we do? The scientist in me says we should be doing more of that. Because you know why? The reality, this isn't just philosophy, the reality is, in your country and my country, we have done dozens of things. The ministry or whoever it is in charge has done dozens of things to intervene in the health system. And for most of them, we only have a hunch whether we've done any good. For most of them, we don't know. We actually may have made things worse and killed more patients and reduced the quality of care by our actions, but we don't even know. Now, when I say this to politicians, I am not very popular. Doesn't stop me saying this to politicians. So you don't have to be crazy to be a researcher, but it helps.
But I guess one of the problems is keeping things the same in the two groups. But if the difference between the two groups is not what we expect them to do, but what we do to them,
yes,
then we are better able to be in control. And that's actually what that's a kind of description of the trial we're doing at the moment. Because we don't say to the two groups, we expect you to do this and you to do that. We expect them to do the same, but we do different things to them, and that's more handleable.
Yeah, sure.